Good afternoon, and thank you for your support of the Singapore Actuarial Conference this year. As the theme of the conference is COVID, I volunteered to provide a tour of information produced by the Ministry of Health in Singapore in relation to the COVID-19 pandemic. So while I'm sure most of you listening today have seen the daily updates in the Straits Times or by Channel News Asia, people I talk to are often surprised by the level of detail that has been published over the last 18 months and the insights found by linking the data in more detail. So after a little background and some caveats on using public information, I'll introduce you to some of the types of data available beyond that seen in the headlines, talk you through a few charts relating to Singapore's experience before looking at some implications for the results and making a quick comparison between Singapore and some other countries I've taken a look at. As I noted earlier, all of the information I have used for this presentation is public information. Most of it has come from the MOH website, which contains a mix of live tables and reports. The reports have the advantage of being archived and so available to go back and review if one has missed a day. Unfortunately, there is a fair amount of live data, particularly in the early months of the virus, which gets overwritten on the website and so disappears. As a result, there are often gaps in the data if a piece of live data is missed. Further, this is a live situation, and so the data presented changes according to public or political interest, perceived relevance and interest, or simply no longer considered worthwhile. Hence, the data available changes with each update, leading to more gaps in the data and difficulties in interpretation over the 18 to 20 months. I've also sourced additional information from Google's COVID statistics and Worldometer for some of the non-Singapore data found in the final section. Like most countries, Singapore's focus, until recently, has been on the number of cases reported. There were numerous ways in which the count of cases was split, such as source, citizenship, detection, and age. However, in more recent months, the focus has shifted to severity. As Singapore and other countries moved away from a COVID-0 approach to one of treating the virus as endemic, then the number of deaths or the capacity of the medical industry became the prime concerns. So reporting on care status and the progression through the treatments gained prominence. For the purpose of this presentation, I've incorporated data from February 2020 to mid-November 2021. So let's begin our tour. One of the most commonly reported pieces of information is a daily situation report published by MOH. While the format has changed several times, most of this information has been available from the beginning. Items such as the total cases reported and the daily increase, the number of cases active and in isolation, hospital or ICU, or have passed away. There are also further tables on the number of people asked to stay home or in quarantine. Some of these tabs include charts which allow the history of the disease to be observed. In this example, we have the number of cases reported each day, with a 7-day average split by the source such as imported, community, or dorm residents. In this chart, the initial circuit breaker that occurred April to June last year is highlighted in grey. I have now superimposed the more recent restrictions around closing or limiting access to F&B or guests or activities. Looking at the number of community cases now compared to those in the past, one could wonder what all the fuss was about back then. I've also included a line showing the announcement by the government of a change in strategy in accepting that the virus is now endemic and how the experience has developed since then. While the reports don't explicitly tell how many cases have gone into hospital or ICU, they do provide a snapshot each day of how many people are in each care status. From this series of charts, it is clear that while the number of cases in isolation has spiked over the past 2 months, the number going to hospital has not been as great, though ICU and death rates do appear to be spiking. Looking at the overall number of cases on a log scale allows us to see the growth in cases more clearly from week to week. Each line is a doubling of the case numbers, so the steeper the gradient of the curve, the shorter the time for the number of cases to double. We can see in late July of 2021, the number of daily cases went up by a factor of 4 over a period of under 2 weeks, before halving again over the following months, before accelerating again to double each week or so for the next 3 to 5 weeks. The daily number of cases has been relatively stable since about mid-October. A current favourite from MOH refers to the weekly change in the number of cases. This shows the rate of change of the previous chart, where a value greater than 1 indicates an increasing trend, while those lower than 1 are decreasing. During the majority of 2021, there was lots of volatility as the number of cases was very low. However, more recent weeks have seen a gradual decline in the growth rate to be now hovering around a value of 1. The multi-ministry task force has indicated that restrictions will start to relax once the sustained value of below 1 has been achieved. The reports have more recently been showing the number of cases reported by age of infected. Combining this with population figures shown elsewhere in the reports, it is possible to see how the infection rates have varied by age. It is clear from these charts that while the number of infections is concentrated around the middle ages, once the size of the population is considered, the infection rates are actually quite similar. In fact, since mid-July, as the overall infection rate has increased significantly, it has increased across all the age brackets similarly, with no material difference in their relative infection rates. One key determinant in the number of cases detected is the number of tests done. Donald Trump famously requested that hospitals reduce the number of tests so as to reduce the number of cases. Singapore was averaging around 40,000 swab tests per day from the middle of last year to the middle of this. The number of positive tests during this time was around 1 per 100,000 tests. Since the various lockdown restrictions started, the number of tests increased to average around 60,000 per day. The positive result rate increased to about 1 per 10,000 up until late July. Since then, the positive test rate has continued to increase until it reached 1 in 20 by mid-October. An increasing positive test rate is widely considered to reflect an increase in the undetected case rate. As such, despite the rapid increase in case numbers from September to November, this chart suggests that the actual number was probably even higher. With the shift to the new normal, the number of swab tests conducted has reduced, as not all positive ART tests will result in a PCR test, and so the number of tests has dropped significantly in recent weeks. Though Mr. Trump's prediction that this would reduce the number of reported cases is yet to be seen. Using public data does also subject the reader to some potential unexpected horrors. In this case, I have lifted this pie chart from the reports to A. warn the unsuspecting reader of what to expect, and B. show just how dominant the asymptomatic or mild case numbers are out of all the cases reported. This highlights one of the reasons why countries are moving away from a case to a severity approach in monitoring the disease. While the proportion of cases that required hospitalization has been volatile over the past 20 months, the last few months have been some of the lowest. However, the proportion of hospitalized cases that deteriorate to requiring oxygen has increased, as has the proportion of hospitalized cases that require ICU. This likely reflects a change in the process, in that the severity levels required for hospitalization have increased. As well as tracking the week-on-week ratios of the number of cases, it is also possible to track the ratios for different levels of severity. Interestingly, the growth trends are very similar for all severity levels. As well as tracking the number of cases by age, we can track the severity of the cases by age. So while the virus appears to infect reasonably consistently across all ages, the reaction of the body varies significantly by age. All levels of severity increase with age, except for 0 to 11-year-olds in hospital, which is more likely a procedural result rather than a true reflection of the severity of the illness. Looking at this a little closer, we can see that the probability of requiring oxygen, ICU, or dying is relatively low until the patient enters their 50s, and then the rates increase rather quickly. However, once the patient requires oxygen, the probability of moving to a higher level of severity increases significantly, until we reach the highest severity levels, where as the patients get older, the probability of dying in ICU is very high. One of the most politically sensitive areas of interest has been the number of imported cases. From this chart, we can see that other than a handful of periods where the average daily number of cases approached 30, generally there have been less than 10 imported cases per day. For a short period, from June 2020 to June 21, the MOH provided data on the number of arrivals each week and the number that tested positive at arrival. They also provided further details on the number of S- cases. These are essentially cases where the person tested positive at arrival under the PCR test, but further tests indicated that they were recovering from an earlier infection and so no longer infectious. The proportion of cases that were asymptomatic and so would only be shown as a positive test because they were traveling and so being tested was also provided, and consistently found to be around 90%. What was interesting is that the results suggested between 0.5 and 1% of passengers arriving at Changi were producing positive tests. At that time, the reported case rate for the countries from which these travellers were arriving from was a fraction of that. Hence the assumption that the true case numbers in those countries was probably much higher than being reported. As MOH stopped providing this data, I took some data from STB on a monthly basis. Again, we can see that the arrivals positive results was running at around 2%, but looks to have dropped to 1% over the past couple of months as the number of arrivals has increased. This is likely due to the additional restrictions and testing on travellers passing through the new vaccinated travel lanes. Globally, one of the most divisive topics over the past 6 to 9 months has been the COVID vaccines, with strong opinions on both sides. Many people are hesitant about getting a vaccine for several reasons, such as concerns regarding the unprecedented speed of the approval process for the various vaccines. Some believe the vaccines are unnecessary as they already have protection, and some just don't like being told what to do. While others are concerned with, shall we say, side effects. But a large number of people are comfortable and even supportive of the whole science approach to the solution. Singapore has generally been supportive of the vaccination drive, with a strong take-up of the free vaccines on offer across all age groups where vaccines are available. Singapore now stands with over 85% of the population fully vaccinated, and if we exclude the 9% of the population who are too young to be vaccinated and the roughly 1% who are medically unable to be vaccinated, then over 95% of the eligible population has in fact been vaccinated. However, even Singapore has some degree of vaccine hesitancy. This can be seen by the number of people who have been willing to skip the free vaccines and pay not immaterial sums to be vaccinated by another version of the vaccines. Note the drop in the WHO vaccines at the end of October as Sinovac was moved across to the national program. So there have been more than 120,000 people, about 2% of the population, who did not feel comfortable taking the free vaccine available, and there still remains about 250,000 people who are eligible for the vaccine but have yet to take up the offer. So, if we review the charts where we saw the different levels of severity by age, we can see that the vaccinations are having a material impact on the probability of requiring oxygen or once more testing positive. The results are virtually nil until the patient is in their 60s, and then increases much more slowly than the unvaccinated rates. A similar pattern can be seen for the probability of ICU or dying once oxygen is required. However, vaccines appear to have a more limited impact on the probability of survival if ICU is required. We can see the impact of the vaccine on severity is greatest for the younger ages and for the lower severity levels. This trend can also be seen using a different set of data, where the hospitalization rate for vaccinated cases is around 1/6 of that of the unvaccinated cases. The usage of oxygen is about half for the vaccinated versus the unvaccinated, though again the benefits of the vaccine on the transition to ICU once oxygen is required is less conclusive. However, the recent surge in the number of cases has occurred despite the high levels of vaccinations observed. Unfortunately, some of the data is no longer provided, but combining various tables to determine the infection rates by vaccinated and unvaccinated cases, it appeared that the vaccine had a limited impact on the probability of testing positive. This experience was also demonstrated in a recent UK study, which found that the Delta variant easily transmitted through vaccinated family members. However, 2 recent Australian papers suggested that vaccinated people were far less likely to contract the virus and so test positive. More research needs to be conducted in this area to determine the discrepancy. Is it the different vaccine types being used, or different variants at the time of the study? But many of the restrictions and mandates being applied around the world are done on the premise that the vaccine stop transmission, not just reduce the severity. The next phase in the vaccine story are the use of boosters. Again, residents of Singapore are being offered a free vaccine booster to counter the potential decline in effectiveness of the vaccine over time. To date, over 22% of the population have accepted the offer. While the results are early, it does appear that the boosters are having an impact on the severity of the disease. From the first chart, we can see that the people who are fully vaccinated have about 1/8 the chance of requiring oxygen in their treatment compared to the unvaccinated population. The experience of those with boosters looks to be about 1/8 again. However, the boosters again look to be less effective at the more extreme illnesses, with the probability of moving to ICU once oxygen is required being fairly consistent regardless of whether they vaccinated or even boosted. As part of my studies and interests, I've looked at the experience across a number of countries. This chart shows the number of cases reported per person over the week to 14th November. As you can see, the Singapore experience is relatively high. However, there has been a lot of variation between the countries over time. I show here the movement of countries between different incidence bands that I have modelled. It is clear for most countries there is a lot of variation in their incidence rates over time, and the current incidence rate may not be representative of where the country will be in a month or two's time. The following matrix shows the weekly movement of countries over the past 20 months. We can see that most of the time a country will remain in the same band, but there is a significant chance of moving up or down the bands each week. However, after initially low rates in 2020, the average incidence rate has generally increased, with a dip in June possibly reflecting the overweighting of Northern Hemisphere countries in my selection. I've also made a comparison between the incidence rate, frequency, and the number of deaths per case, severity. While there is a range in the results, both on frequency and severity, I found it interesting that no country that I have monitored has experienced both high levels of frequency and severity. If we take a look at the management consultant's favorite 2x2 chart, we can see most countries have both relatively low frequency and severity. A few have high severity but low frequency, such as China and Taiwan, and a few have low severity but high frequency, such as the UK and the USA. But none have high levels of both. It is open to debate as to why countries have outsized death rates, but one suggestion is that the number of cases reported has been underestimated, thus artificially inflating the death rate. One other area I reviewed was the claim that countries need to be careful to keep the numbers down so as to avoid a collapse in the national health systems, leading to an increase in the death rates. While the medical staff have undoubtedly done a fantastic job across the world under very trying circumstances, there was no example I found in the countries I modelled of the death rates increasing as the number of cases rose, thus reflecting a catastrophic strain on the medical systems. Rather, the UK is a prime example of the patterns I saw. Initially, even though the case rates were relatively low, 40 to 50 people per million population infected, the death rates were high, exceeding 10%, as medical staff did not have the best procedures in place to deal with the cases. Things then settled down, but when the next wave hit and case numbers rose to more than 600 infections per million, the death rate rose only moderately and to a much lower rate than the first wave, 2 to 3%. By the time of the third wave, when infections again reached several hundred cases per million population, by now the procedures and vaccinations meant that the death rate was much lower, rising to only 0.5%. So while there were small increases in the death rates as infection rates rose, these rises were dwarfed by the reductions made through vaccinations and better processes. This pattern is repeated to various extents across pretty much all of the countries I modelled. One special mention should be made of China. The reason for the high death rate is that China has only recorded one wave with high death rates while processes were determined. Since then, there have been relatively few cases reported and virtually no COVID-related deaths reported since the middle of 2020. So what does this all mean? Clearly, if you are developing an insurance product, say one to cover passengers arriving in Singapore for the cost of any COVID-related medical expenses whilst they're in Singapore, it is important to differentiate the premium by factors such as age and vaccination status. Also note that the experience can change dramatically and quickly. For example, Singapore changed from 1 to 2 cases per day to 3,000 in a few short months. So any pricing regime needs to be able to respond to this. There is plenty of public data available, but there are lots of gaps as well, so you need to be careful. While it is clear that vaccines help to prevent serious illness, if there is a question as to whether they reduce the chance of infection, even asymptomatic infection, then many of the current restrictions and mandates around vaccines should be rethought. What is the way out? With many European countries considering or re-entering forms of lockdowns, and Singapore expressing a wish to avoid making U-turns on the path to normalcy, what does this mean for the future? While it looks like travel continues to open up for many countries, normal day-to-day life may not return for some time yet. Finally, as I'm sure you're aware, Singapore loves the 3-letter acronym. How many of the following are new to you from the last 20 months? Do you know them all? Thank you for your interest and participation. I'm now available for any questions that you may have. Hey, Mehul.
You can hear me now. Thank you for that, Matthew. It's very detailed analysis, and I'm sure there's a lot of data sitting behind that that people are probably still digesting. So we haven't had a rush of questions that have come in. We're just conscious of time. Maybe just a quick question from me. What would you say has been, while going through the data, something that has been counter to the broader sort of messaging or perceptions that sit out there as a result of the analysis you've done?
I think the key one's got to be around the frequency. As I mentioned in the report, that it's quite clear that the vaccines are having a big impact on the severity. So you're far less likely to get seriously ill if you've been vaccinated or not. However, a lot of the vaccine mandates, you can't go to work unless you've been vaccinated, you can't go into a shopping mall unless you've been vaccinated. All of these things are not so much about protecting the individual from getting seriously ill. They're based on the presumption that vaccinations stop transmission between people who are mildly ill. And I say, so whilst there's some studies in Australia which suggest that that is the case, the work that was done that I was doing earlier in the year when the data was available suggested that the number of cases reported by vaccination status was not really that different. It was at that next level of hospitalization that it really kicked in. So that was one of the things that I found most surprising and was quite curious. It was a shame that the data coincidentally stopped when it was showing that story, but I wouldn't mind exploring that in more detail if I'm able to dig out some data. But yeah, that's for me, it's got to be one of the most surprising aspects of the study I've been doing.
Okay, that is quite interesting. Thanks for that. And I'm sure there's another question that's on everyone's mind, which is where can they get a hold of those T-shirts that you put flashed up? I'm sure you'll be inundated with questions on that.
I gotta say, what sells counterculture like a T-shirt? So yeah, they're available online.
Great. Thanks, Matthew. That was really interesting.